as well to, as you know, the dilemma of leaving no one behind, universal health coverage efforts towards leaving no one behind. So the department, through this strategy, through the implementation of this strategy and operationalizing the work around gender and intersectionality, supports and promotes an intersectional gender approach to research, focusing precisely on those impacts of how gender dynamics and how gender dimensions and their connections with other drivers of inequity impact health experiences, as you can see in this adapted intersectional analysis wheel on the right-hand side, where intersectional gender analysis is used with gender as the entry point for a deeper intersectional analysis. So the main focus of the core areas of the strategy cover: first, building research capacities on intersectional gender analysis in research on infectious diseases. Secondly, supporting intersectional gender analysis in research for implementation, a key area of work, research for implementation, basically to generate new evidence, new knowledge on the intersections of gender and other social variables, other social stratifiers that influence the way in which those implementation strategies work. Also generating evidence on how those gender intersecting inequalities and inequities affect access to healthcare and access to health services, and those that influence differentials in vulnerability to an impact of health conditions associated with infectious diseases. And lastly, promoting an inclusive infectious disease research agenda. The main objectives of the project for the three hubs, the ones that are shared by the three hubs, include: first, better understand and explore gender dimensions and their intersecting social stratifiers at community level, precisely where those social innovations operate. Generate evidence-based lessons that can be used for research capacity strengthening and to generate also policy recommendations to inform policy. And lastly, to disseminate, promote, and advocate for an inclusive research agenda, as I mentioned before. So these are, in a nutshell, the key elements that I wanted to share with you. I thank you for your continued attention to this important area of work. And now I invite the hubs, because they're the true starts of this initiative. And I thank you, Arthur. So now the floor is yours. Thank you.
Thank you, Mariam. So again, welcome everyone to this session entitled A Closer Look at the Social Innovations in Health, Examining Gender in Intersecting Social Stratifiers at the Community Level. So we have an esteemed panel of researchers and project leaders and experts who will shed some light on this important topic. So joining us first are Laura, Sofía, Zuluaga, I hope I pronounced it right, and Charlotte Scott, researchers from SIHI Latin America and the Caribbean, and Dane, who will present on the intersection of gender with other social stratifiers in prevention and control of infectious diseases in indigenous and Afro-Colombian communities in Puerto Rico, Colombia. This will be followed by Dr. Jana Deborah Mier-Alpaño, the hub manager of the SIHI Philippines hub, who will discuss applying an intersectional gender lens on community social innovations in health. And then finally, we have Dr. Phylllis Awor, the hub lead at SIHI Uganda, who will present on gender dimensions and access to healthcare in Uganda using an intersectional gender analysis lens to examine social innovation in health project. So without further ado, let's dive into their insightful presentations.
Hello, everyone. Thank you for having us, and thank you for being here today. We're going to start our presentation because we know we don't have that much time. Can you hear me?
Yes, we can.
Yes, we can hear you.
Okay, so as it was already mentioned, our project is the intersection of gender with other social stratifiers in the prevention and control of infectious diseases in indigenous and Afro-Colombian communities in Pueblo Rico, in the context of social innovation in health programs. So a little context about Pueblo Rico before starting the presentation. It's a majority rural town with about 30,000 inhabitants that are 50% Afro-Colombian, 36% indigenous, and 48% mestizo. The mestizo population lives in the rural area of the municipality. The Afro-Colombian lives in smaller rural areas or their surrounding urban rural areas. And indigenous population, which are Embera, live in the most remote and isolated rural areas of the municipality. The entire population has been impacted by the Colombian armed conflict, and they have experienced high levels of multidimensional poverty. The starting point of this research is that we have been working in Puerto Rico for 3 years with projects of social innovation, and we noticed limited participation of women in these projects, especially in Embera women, and we wanted to understand why this was happening, because we are starting now a new project in this community, and we wanted to ensure that there was more equitable community participation. So in this project, our objective was to understand how gender and other social stratifiers such as age, ethnicity, and rurality affect the participation in social innovation in health related to infectious diseases in Puerto Rico. So what we did was, very quickly, was to do 10 interviews. Sorry. Okay. Do 10 interviews with women in the community. It was also followed by 2 workshops with community health leaders, which was what we were kind of planning to do, and then an opportunity to work with students from the 10th and 11th grade came up, and so we decided to also take this opportunity, and because we think this subject of gender and intersectionality is very important, so we wanted to reach as many people as we could. We also did focus groups and 3 audiovisual workshops where we produced a video co-created with the community, which was a very kind of rewarding job. Beyond this, we wanted to make sure that what we were saying was something that the communities agree with. And so we did a kind of preliminary sharing of the results of this research with institutions, with community leaders, social organizations, students. We just wanted to show them a version of what we are presenting here today to make sure that it was, that they thought it was adequate or that it was true. And so that also took place. So a little bit of the kind of results of our research, we identify barriers and facilitators for equitable community participation in health initiatives with ethnic groups in Puerto Rico. So first we talked about this domain, that access to resources. And here we talked about 2 things: education, which what we found in terms of barriers was that there was a limited access to higher education for Embera and Afro-Colombian communities in Puerto Rico, especially Embera, the Embera community, the indigenous community in this municipality. And this has led to a limited capacity building and also a lack of confidence, especially for the Embera community, who also face some language barriers because Spanish is not their first language. So what we saw here was that a lot of them feel intimidated when participating in health spaces, in health programs, because they feel they have less education, they feel they don't know how to speak Spanish well, so they don't have the confidence to participate. Some facilitators that we found in terms of this is that there are some informal educational initiatives taking place in the municipality, which are helping create or facilitate capacity building. And there's a strong motivation, especially among the Imbera community, to participate. In terms of economic resources, we noticed that we found that there's a limited access to well-compensated jobs, especially again among the Imbera community who live in the more rural and isolated areas. And this means that they can cover the cost of participation in the different health programs because they have to travel long distances and pay money to get to the places where these programs usually take place. There's also here a barrier that affects women in particular because they are economically dependent on their husbands. The big issue that limits their participation a lot more than the rest of the population. One facilitator that we found was that among Afro-Colombian women, the younger Afro-Colombian women, they're having more access to independent salaries and are not dependent on their husband or not as dependent on their husbands. So this has facilitated their participation. Okay, in terms of beliefs and perception, we talk a lot about autonomy because it was identified by indigenous women as their main kind of barrier. There's this belief of women's subordination that leads to the Imbera women having limited autonomy to make decisions, and this may lead to being less confident and feeling less capable. When we talk about limited autonomy, we mean they need permission for everything. They need permission for studying, for working, for living their communities and going to the rural area where they can access healthcare. So it's a very limited autonomy that affects their confidence and makes them feel less capable because when they are able to go and participate, they haven't had that experience of being taken into account or being able to make their own decisions. So they don't feel as confident doing it because they don't have the experience. Afro-Colombian women also face resistance to being leaders. So in the facilitators, we point out that they have a greater, Afro-Colombian women have a greater influence in family decisions due to a matriarchal tradition. And this is true in their families, but when that wants to extend to a community level, there are obstacles for that to happen. In terms of social recognition, the barriers in Afro-Colombian communities are undervalued and they face social exclusion, discrimination, and a lack of recognition outside their community. So they're seen as less capable than others. And this leads to all of this. And women not only face this outside their communities, they also face it within their communities. These can manifest in low self-esteem, lack of confidence, and lack of motivation. This is especially true or was especially mentioned by Afro-Colombian women who talked about their age, their experience being used as reasons for not letting them participate and not giving them support and the recognition. And these are not usually things that are held against men, this lack of experience or they. So this leads to a lack of motivation and a reluctance to participate from Afro-Colombian women. Like they're going to put barriers anyway. So yeah, this affects their motivation. And even when they get to positions of leadership, they're faced with a lot of criticism and stronger criticism that men usually get. In terms of social practices, we talk here mainly of caretaking practices, which is a big barrier in terms of women are in charge of housework, childcare, the care of sick relatives, and this makes leaving their homes and leaving them for long periods of time very difficult, which affects participation in health programs, in different initiatives that may take place in the municipality. In terms of facilitators, for men, the lack of these household responsibilities is a facilitator to participate, because they don't have to look who can take care of their children or who can do the housework while they're gone. There's also the ability to bring children to activities is a facilitator for women that we have started to implement, and it has worked well. And there's also these strong support networks to support these family care responsibilities is also a facilitator for women, but it's almost always, the support networks is almost always made up of other women, their mothers, their mother-in-law, their children, their daughters when they're old enough. And in terms of participation, there's some barriers related to leadership positions in Embera and Afro-Colombian communities occupied mainly by men. So women often think it's impossible to occupy these positions. In terms of facilitators, the support of indigenous authorities is a big facilitator. So you always have to get approval by indigenous authorities to involve anyone from the indigenous community to participate. So getting their support is like the first step to any program working. There's also women in visible leadership positions is another facilitator. There are not a lot of them, but usually the few that are seen as like heroines and are an inspiration for other women to participate. So they are kind of a facilitator, because other women start to see that it is possible to participate and to occupy leadership positions. And lastly, the growing interest among Embera women in participation and leadership is a huge facilitator. And as a conclusion of this part, although the Embera community encounters the greatest barriers, so all the barriers I mentioned apply for indigenous and Afro-Colombian communities, but they affect especially the Embera community. And even if this is true, the potential for equitable participation is greater in Embera communities due to the strength of their social organization. So if you get the approval and the help, the support of the indigenous social organization, you will get that participation, which is not the case for Afro-Colombian communities. Their social organization is not as strong. So generating motivation is key. Individual motivation is for having them participate. And lastly, although it is more difficult to involve women consistently in health initiatives, their high level of motivation and commitment is critical to achieve a long-term participation process, especially among the Embera community. Now, Charlotte is going to talk to you a little bit about something else.
Yes, I'm just going to briefly move on to describe some of our reflections on incorporating this intersectional gender lens into research on social innovations in health. So overall, we found that this facilitated participation among these population groups that we had seen in the past had historically less representation. So we've classified these impacts into 5 theoretical areas within the framework of social innovation in health. Next slide. So within the first area, which is diversifying actors, we involved more diverse actors in the research activities at every step of the process, which reflected positively in our more inclusive research results. So in years past, we did find relatively low participation of women in research activities that had been implemented in Puerto Rico. But through applying this intersectional gender lens, we began to see a greater participation of women in the workshops, interviews, focus group discussions. And this later allowed us to gain a better understanding of the perspectives and realities of Embera and Afro-Colombian women in Puerto Rico. Additionally, we hired Deborah and Afro-Colombian women as field coordinators to recruit participants for data collection, and this also led to more representation from these population groups. Secondly, looking at equitable community participation, this also allowed us to consider new perspectives when developing creative solutions to these health problems that were identified by the community. And these trusting relationships have been forming over the years due to working within the same community throughout several years in the past. And building these trusting relationships with the local social organizations like the indigenous government during the previous health interventions that have taken place in the same setting. But promoting the participation of women, and especially in Barrio, still remains a challenge. So applying this intersectional gender lens allowed us to kind of initially identify which barriers the community members encounter to participate in health interventions, which led to greater diversity and representation during research activities. Next slide. So within the prior community visits, we really noticed these clear divisions of power by ethnic group, which is why we chose ethnicity as one of the social stratifiers. And looking closer at this context, we saw how these divisions deepen even more when we're considering other social stratifiers like rurality, age, gender. So these societal norms have led to some resistance to opening the floor for participation of more diverse actors, such as Embera and Afro-Colombian women in community organizations. So the health needs of those with less presence in decision-making spaces became more visible through these more inclusive recruitment strategies. With creative solutions in social innovation and health, which is key to this social innovation and health framework, this is developed through this equitable community participation. So we employed various co-creation methods throughout this research project. And by applying an intersectional gender lens to this, we focused especially on women's roles in transforming the reality of health in their own communities, and co-creating these solutions that incorporate and consolidate the perspectives of all population groups of different ages who belong to different ethnic groups, can also have a positive impact on the inclusivity of the solutions and in turn, the reach of their impact. And lastly here, the research activities went beyond collecting information and also generated spaces for dialogue in the preliminary presentation of the results, in the focus group discussions, and learning within the entire community on the topic of equitable participation in health initiatives. So with applying this intersectional gender lens to the workshop, this allowed more community members to become aware of how these problems differ among different population groups, and gain awareness of the importance of participation equity, which later down the line has impacts on social and institutional transformation. Next slide, please, Sophie. So throughout this project, we reflected on what the implications of our research is and how we can form these into actual recommendations for carrying out research on future community engagement projects in both this context where we work at SIHI and in contexts similar to it. So first, we think that applying an intersectional gender lens in all phases of the research process is a great way to promote greater inclusivity at all stages of the research, from proposal writing to results dissemination and beyond. Second is to involve more diverse actors as field coordinators, which helps to facilitate recruitment among population groups with less representation. In our case, these were Embera and Afro-Colombian women. Third is to generate trust with the community and local social organizations, which makes uptake and acceptance of these initiatives more likely. In our context, this was particularly important in gaining permission from the indigenous governor so that the Embera community could participate in our research activities. Fourth, reducing communication barriers, like Sophie mentioned, through utilizing translators. This is very important, especially in recruitment and then in the actual activity delivery. And this is in addition to having culturally and linguistically appropriate and also hands-on teaching methods that are interactive when disseminating learning packages in the community. Fifth, it's important to evaluate whether the program is truly responding to the community's needs through constant feedback from them. And then lastly, the self-reflexivity from the part of the research team is very important to ensure that an intersectional gender lens is being considered. And we think that this would be great through a checklist with indicators that can ensure it's being constantly applied. Great. So this is the end of our presentation, but thank you so much for listening, and we'll move on to the next hub.
All right. Can I just please know if my slides can already be seen?
We can see it, Han.
Okay. Hello, everyone, and thank you for this opportunity for us to be able to share our work. So for this project, our aim was to conduct research on 2 social innovations in health to understand how intersection of gender and other social stratifiers interplay with and shape social innovations in health at the community level. But for this presentation, in the interest of time, we will just focus on one of the 2 of the social innovations that we studied. And this innovation is the holistic water systems for pumping water uphill, which was initiated by the Alternative Indigenous Development Foundation, or AIDFI. So we'll just call this the AIDFI ramp pump. And this AIDFI ramp pump helps villages across the Philippines to gain access to clean and safe water. They developed this mechanical or hydraulic ramp pump model, which is made of locally available materials that pumps water uphill to remote upland communities. And this has improved the lives of the community members in terms of health, nutrition, and sanitation. But also, beyond meeting this basic need of water, the innovation has also changed the social and economic landscape of these communities. And this innovation also has a strong community engagement component, wherein the communities are facilitated to form their local water associations and are even trained to maintain their own ramp pumps. And this has made it possible for the community members to take ownership of the initiative and to even do more for their community. Now, just going back to our research, to help ensure that we had a gender-sensitive methodology, we submitted our protocol and tools to the Philippine Social Science Council's Ethics Review Board, and they gave us helpful comments and recommendations. In general, our research process involved both primary and secondary data collection. So we conducted desk research first to produce a brief literature review and situational background. And then for the primary data collection, we conducted site visits to 2 communities, in-depth interviews with key informants and community members, and then focus group discussions, particularly with women involved in the project, to understand the perspectives of the different stakeholders. And in our interviews and FGDs, we asked about these elements, such as roles and responsibilities, perceptions on gender roles, particularly when it comes to water, household, and livelihood, participation in the innovation, and also the impact of the innovation. So here's just some photos of the research team trekking to the upland areas where the communities are situated. And we also see the ramp pumps in action, which again, deliver water to the upland communities. And for our results, in our qualitative processing, the coded responses resulted in 67 units of analysis, which led to 12 categories. And these were further synthesized into 5 sub-themes about the ramp pump project. And then we put them together with the sub-themes of the other innovation, and these form these 4 overarching themes. So the first is the impact of gender, geographic location, and socioeconomic status to health outcomes. The second is that social innovation in health creates opportunities for community participation, improving health outcomes and social impact. The third is that gender norms, gendered labor, and volunteerism all influence the participation in social innovation. And finally, that social innovation in health is intentional in addressing intersecting vulnerabilities. So let's just go through each of the themes one by one. The first theme is the impact of gender, geographic location, and socioeconomic status to health outcomes. And in this social innovation case, we saw observable intersections in gender and geographic location, which affect the experience of health and health conditions. So for one, since these are upland communities, geographic factors already come into play as a major determinant of health. So the topographical challenges and the geographic isolation make access to health service difficult, and even access to other basic necessities such as water, which of course impacts health and well-being in terms of sanitation and hygiene. And then in addition, while interview and FGD participants claim that everyone, meaning all genders, share the responsibility of water, anecdotally, they share that back and neck problems disproportionately affect women because they fetch water more than men. And women are also in charge of laundry, of washing clothes. So prior to having the ramp pumps, they would have to go downhill or down the mountain to fetch water, and already bringing also their laundry there, and then hike back up, bringing all of these. And these activities contribute to the exacerbation of their back problems. Now, the second theme is social innovation in health, creating opportunities for community participation, improving health outcomes, and social impact. So under this theme, what is highlighted for the AIDFI Ramp Pump is the demonstration of community engagement, empowerment, and co-ownership of social innovation. So as explained by one of the community organizers, it involves the community. They are involved in enterprise training where they are taught to maintain and operate the project, including how to create policies for water use and financial aspects. We merely assist, it is still them making decisions. And the whole social preparation process here, which involves gathering the community, enabling them to establish local water associations and then elect their own officers, and then hiring and training local water technicians, and even involving the community members in the actual installation of the ramp pumps. All of these promote the co-ownership of the social innovation and empower the community. This even enabled them to join local development councils, have more partnerships and more community projects because they are already organized. The third theme is that gender norms, gendered labor, and volunteerism all influence participation in social innovation. And specifically for this innovation, we saw that gendered division of labor influences the participation in the innovation. So it was observed that women were more noticeably more eager to be involved in the ramp pump project because it is about water, and water is a crucial resource of the household, and the household is traditionally viewed as the woman's domain. And it was also noted that while people of all genders actually work in the communities for their livelihood, women are still largely the ones viewed to be responsible for the children and for taking care of the family. So, for example, when we asked, what if both parents are in the sugarcane fields working, who is responsible for the children? And the community members answered that, for instance, if there is a meeting at school, it's the woman who will skip work to attend, and the men will stay and continue working. So we have seen that this leads to women doing a balancing act, actually juggling their work or their livelihood, their household, and even their volunteering and leadership roles in the community. And the final overarching theme is that social innovations in health are intentional in addressing intersecting vulnerabilities. And in this AIDFI project, we saw that the holistic approach of social innovation is the one that really intentionally aims to address gender and intersecting stratifiers. We learned that the core values and history of AIDFI as an organization reflect why it takes a holistic approach in solving the issue of lack of water. And this value of theirs of having a holistic approach is what inspired the whole social preparation and community engagement process for this ramp pump project. And again, this is all geared towards letting the community take ownership of the initiative and empowering them so that they can even continue working together as a community to address other needs. And now to summarize our findings, we used this framework by Dr. Van Niekerk and colleagues in their paper, The Application of Social Innovation in Healthcare, as it nicely summarizes the components and process of social innovation. But here we adapted it to note that gendered health determinants, meaning the gender norms, roles, and relations, intersect with the other social determinants like socioeconomic status and geographic location. And all of these influence what the health challenge is and how it is experienced. And this is the stimulus for social innovation. But we also note that gender and other social stratifiers, of course, not only influence the challenge, but also all the other aspects of the social innovation process. That's why we put a line encompassing the whole process. And then here we mapped out the themes and integrated them into the adapted framework. So again, at the start, you can see gender and other social stratifiers influencing the experience of the health and health challenges, such as the lack of accessible water. And this relates to the first theme. And then in the component of participation, this relates to the second theme, which is social innovation in health, creating opportunities for community participation, improving health outcomes, and social impact. So we saw that the participation of community members, particularly that of women, creates new forms of social relations due to their new roles and responsibilities, such as in the local water associations. Theme 3 also relates to this, to participation, as we saw that the gender norms and gendered labor influence how people participate, or particularly women, how they participate in the social innovation. Our fourth theme, which is that social innovations in health are intentional in addressing intersecting vulnerabilities. This can be directly related to the creative solutions or the innovations themselves. So the solutions we saw are tailor-fit to the community's needs and in the social-cultural spheres in which the lives of the people are embedded in. And again, the solutions are holistic in their approach. Theme 2 is also related to empowerment. Now, we saw that because of the participation in the innovation, the community members are even more empowered to take charge of their own health. They acquire new collective capabilities, and this enables them to achieve, again, other goals and address other needs of the community. And ultimately, this is what results in change at an institutional or systems level and has greater societal impact. And now, having gone through this whole research process, our calls to action are the following. So on designing and implementing gender-responsive social innovations in health with communities, continuous conscientization about a world shaped and ruled by men should still be pursued, particularly through doing gender sensitivity training in organizations, government agencies, and even in communities. And at the local government level, ordinances can be crafted to address the unpaid care work of women. And this care work should be taken into consideration in community participation and community engagement activities, especially when we see that it's women that take the load of the volunteer work in the implementation of different programs. When designing and implementing health and development interventions, there needs to be an examination of how gender and multiple social stratifiers, meaning not just one aspect, but how these different aspects interact and affect the community's health and social needs and shape the experiences of people. And again, these should be taken into consideration when we do needs assessment, when we pilot, and as we continuously iterate the interventions. And finally, specifically on advancing gender-responsive research, our calls are to support the generation of evidence on gender inequalities in terms of the access of health services, promote an inclusive research agenda that recognizes the health needs of people in all their diversity, allocate funds for gender-responsive programs, and for funding of projects, require grant applicants to indicate the relevance of gender in their research proposal and how the gender perspective will be applied or integrated into the research or innovation. And when gender analysis or the gender lens is not relevant for the program or study, and I think this should be rare, an explanation should be given by the applicants. I think that, that ends our presentation. Thank you very much for listening. And let's listen next to the presentation of SIHI Uganda. Thank you.
Thank you very much. I would like to request, we only have 10 minutes left or less. So are we going to go beyond the top of the hour? I think that's the question I'd like to ask, please.
Yes, maybe we can spill over around 5 minutes after it, because we started 5-6 minutes late anyway. So thank you, Dr.
Okay,
Phylllis.
thank you. So from Uganda, I will be talking about our work and how, and the topic is really gender dimensions and access to healthcare, using or through an intersectional gender lens on social innovation health projects. The context is 7 social innovation projects, predominantly serving rural communities. However, one included directly serves the urban poor in slums in Kampala, and another one directly serves refugees in a rural area, both refugees and internally displaced people, and another one directly serving disabled children. And these are some of the pictures showing the locations that we are working in. This is the urban slum area in Kampala, served by one of the projects. The objective of our work was to investigate and understand the key gender dimensions and intersectional social stratification that influences health of these populations in order to draw lessons for improvement. And we utilized a mixed method approach with 28 key informant interviews with the staff from the social innovation projects, and 30 in-depth interviews with beneficiaries of the social innovation projects, as well as we conducted a cross-sectional survey with 500 beneficiaries of the social innovation projects. So our results relate to how gender and intersectional social stratification affects health. And we used this matrix, an intersectional gender analysis matrix, in the reference below from WHO. And this helps us to look at how biological and social stratification, as well as gender relations in their different domains, affects illness and health. And our results are presented in terms of the illness domains in the first column, including vulnerability to illness, ability to prevent exposure, and response to illness. So how does gender influence vulnerability to illness? This question was answered using or based on the common illnesses within the areas, including malaria, HIV/AIDS, and other sexually transmitted infections. And unwanted pregnancy was also a key issue for the younger people. So the main finding is that in relation to gender and vulnerability to illness, based on access to resources, there was high knowledge of the common illnesses and how to prevent them. However, limited knowledge on more rare illnesses like disability and, for example, cerebral palsy in children. Now, despite the high knowledge of these illnesses, this did not directly translate into reduced vulnerability to illness because of the other challenges experienced within the different gender dimensions, mainly related to decision-making power. We live in a completely patriarchal society, fully male-dominated social system with almost no autonomy of women, and men have control over everything, resources, and even women's own sexuality. And in that setting, certain norms and values also contribute then to increased vulnerability to illness. For example, acceptance of polygamy and multiple sexual partners, and a few other misconceptions around illness, which I'll not go into detail. But I will move on to then how gender affects ability to prevent. And when I say gender, I also mean all the other intersections of the stratifications affect prevention of exposure to disease. So here now we identified in terms of access to resources, there's high availability of commodities actually for the prevention of these common illnesses that the community was most interested in discussing and that affected the community most. Now, again, we identify high availability of commodities. However, the commodities were seldom utilized, again, due to various gender and social stratification limitations. So again, low decision-making power, making it very difficult for women to decide individually to, for example, reduce number of children they can have, or even just to utilize prevention measures for sexually transmitted infections. And in relation to norms and values, men are reluctant to use certain prevention measures. They don't want to use condoms and the like. And again, we identify that age, gender, and the work that people do directly affects their ability to prevent exposure to illness. And how will gender affecting response to illness? Again, we identify multiple options available and multiple options utilized to respond to illnesses, from seeing traditional healers and other types of healers, as well as the use of modern medicine. But the key underlying issue is that poverty really does constrain the utilization and prioritization of response to illness. So in terms of distribution of labor, employment affects response to illness, with daily wage earners not able to find time to seek care, men prioritizing work over response to illness. And again, the low autonomy of women, where they would need to seek permission and finances for response to illness. Some useful norms or protective norms include, children's illnesses being prioritized for care seeking, but certain diseases also identified, like epilepsy and disability, really is perceived as witchcraft. And care seeking is traditional healers, and this also delays access to more appropriate treatment. So all this, in this exercise, we were really just trying to understand within our population of social innovation beneficiaries, how does gender and some of the intersections affect access to healthcare. We did a survey as well, looking at multiple gender-related indicators, but here I just present to you on gender-based violence. We found that the lifetime prevalence of sexual violence among women was 23%, while among men, 3%. And the prevalence of physical violence within the last 12 months was also high among women, 24% compared to 8% in men. So, and some factors that were associated with sexual violence included occupation, for example, subsistence farmers, and these are generally rural or stay-at-home women, where the sexual violence was more common among them, and also sexual violence was more common from households where men alone made decisions about major household purchases. And also very interesting that we could find from quantitative results is that sexual violence, and even the same result for physical violence, was lower among women whose husbands were involved in domestic work. This we know, but it's interesting to see. I mean, this is could be correct, but interesting to see it from quantitative statistics. So with that setting and context, how then are the social innovation projects responding to these gender and intersecting social inequity, and how can they do this even better? With that, I'd just like to highlight a couple of the interventions or the social innovation projects that we did sample respondents from. So the entire situation I've presented before is actually from the beneficiaries of these projects. But Action for Women and Awakening in the Rural Environment works in a very remote area in Uganda where there is high gender-based violence against women, poor access to education, and women really having limited services and a low voice in decision-making. And what they do is that they empower women and advocate for their rights, empowering women through agriculture and business skills and sensitizing them on their rights, and also provide a shelter for protection of survivors of gender-based violence. Another project, Chaninga Child Development Center, focuses directly on disability in children, and I've shown earlier high stigma related to disability, because most people think it's because of witchcraft, particular certain disability illnesses that certain disability-related illnesses like epilepsy and cerebral palsy. So what this group does is they provide a lot of education and counseling to reduce stigma and rehabilitation and various services to families and children with disabilities, doing most of this in the homes, schools, and through their center. Amani Family Center works in the urban slum in Kampala, providing free and safe maternity care for women, involving men in the maternal health process, from antenatal care to the labor ward, and building relationships with women and with existing social services. And finally, change development initiatives that of the projects I'm highlighting, and this is just a few of all the 7 we worked with this time, focuses on a parenting model that delivers parenting sessions to families, including sessions on bonding and attachment, positive discipline, male involvement in parenting and spousal relationships, and all these are contributing to improved healthcare and reduced inequalities with the different social stratification and really also for women. In conclusion, while we have tried to look through an intersectional gender lens, and even with different vulnerable populations and different stratifiers, social stratifiers, we still identify a predominance of gender-based discrimination against women, including sexual and physical violence, but specifically factors contributing to vulnerability, exposure, and poor response to illness include the highly patriarchal structure of society with low autonomy of women in all aspects. We also identified harmful beliefs that modify access to healthcare and generally the overriding poverty, which leads to deprioritization of healthcare needs. And we recommend that long-term interventions to address gender and social inequity are needed, and they include a focus on family and less on individual healthcare. That includes male involvement in health and domestic duties, but also economic empowerment is key. Some of these interventions we are described, and we can see them actively in the social innovation projects serving these communities. However, the projects need to be further strengthened, supported, and scaled up much wider. So thank you for listening to me. And you can contact us and through our contacts on the screen. So back to you, Art, and to the chair.
Perfect timing, Dr. Phylllis. Thank you very much. For the interest of time, I can only ask one question. So, I mean, I think if I'm going to ask one question, this would be on, and then this is picking up from Hannah's point that gender intersectionality should be and must be intentional. So how can the results that you just presented be applied to other community-based interventions? Not necessarily SIH specific, but I surmise we can always infuse social innovation and health approaches in so many things. But can you be more specific on how these results can be applied in other community-based interventions now? Would like to go first.
Yeah, I think I can go first. I think our recommendations earlier also can be applied. I mentioned it there, not only to social innovations in health, but in health and development interventions in general. However, I think the strength of social innovation, what we're saying, is that it really is intentional in being participatory and people-centered in its approach. And then what we find here, what we have learned in doing this process is that we have to be careful in really looking at gender and other social stratifiers. So in the design, in piloting interventions, and then in iterating them. And in this way, and we've seen it in the studies, in the social innovation examples, that these have potential to actually influence gender and the other intersecting inequities. So for example, with the aid-free ramp pump example, because of the ramp pump, just because of better water supply, the lives of the women changed. Like their unpaid care work lessened because of that, and that they've been more participative in livelihood and economic activities, and that empowered them even further and allowed them to take leadership roles in the community. And now they're having they're being respected in the communities and are able to contribute. Now they have oil making businesses, etc. So it also influences the other intersecting factors, socioeconomic factors for the community. So I think that's the key message from what we learned also.
Thank you, Dr. Hannah. How about from SIHI, Charlotte, or?
Yes, I can just respond briefly to this question, and I very much agree with what Hannah has said. I think at first, kind of considering these questions might feel unnatural and like we're asking too many questions, like it's not how a community might have originally thought of the innovation or the initiative being. But I think maybe in our next steps, working with SIHI or with TDR, kind of developing, some more of these indicators, more of questions that we can ask us when we're writing a proposal, when we're designing data collection instruments, when we're writing papers and disseminating them with the community itself, kind of, some indicators to measure whether we're considering this intersectional gender lens, to what extent, and what we can do to do it even more.
Thanks for that wonderful point, Charlotte. Dr. Phylllis, finally.
So how could the results be utilized with or other community intervention? Well, if you want communities to adopt whatever interventions that you want, they have to participate. And already we can see that all the results are showing us very low participation in activities by different groups, certain special groups, maybe ethnic, maybe women, maybe others. So it's clear that they, in order to get them to utilize interventions or for the interventions to be useful for them, they have to participate, and we really just have to keep this lens of, gender and other social stratification, and that people are left behind either structurally or by certain times we might not know who exactly is left behind. And so the results are extremely important for literally all other community interventions. Over to you.
Thank you for that point, Dr. Phylllis. So a virtual clap again for our esteemed panelists. So we would like to express again our heartfelt gratitude to our esteemed panelists today for your inspiring presentations. So Laura, Charlotte, Dr. Jana, Dr. Phylllis, thank you for your shedding some light on the crucial intersection of gender and social stratifiers in the realm of health and infectious diseases. So the discussions today have reaffirmed the importance of recognizing the impact of gender, geographic location, socioeconomic status, and cultural norms on health outcomes. And it's evident that understanding these intersecting factors is crucial for designing effective interventions and achieving health outcomes for all. So today's discussions also have underscored the importance of applying intersectional gender lens in all phases of research and programming and policy making. And by doing so, we can ensure inclusivity, address power imbalances, and create programs that are sensitive and unique to the needs and challenges faced by the different communities. And as you can see, there are varying contexts that has been presented today. So again, we extend our sincere appreciation to our panelists. Thank you again for your invaluable contributions, and let us continue to work together to create a world where everyone has equal access to quality healthcare and well-being. So I will now turn you over to Dr. Meredith Labarda for some final words, if there are any.
Yeah, thank you, Art. So thank you everyone for staying. And yeah, we're saying now we're closing the SIHI Talks for this month. So we'll see you again for another SIHI Talks next month. So thank you. Have a nice day, everyone.
Yeah, before you leave, we'd appreciate by answering the SIHI Talk survey. We'd like to improve running this webinar series in the future iterations. Thank you.
And thank you, Art, for moderating.